Welcome to Sober Dad Crew, the podcast where we talk about all things sobriety, recovery, parenting, music, tattoos, work, and more. For more information, please visit soberdadcrew.com. My guest this episode is Dr. Jason Cohen. He's an American Board of Urology certified doctor with Cayuga Urology in Ithaca, New York. On this episode, Dr. Cohen and I discuss vasectomies, as well as the men's health issues of prostate cancer and testicular cancer. Just a note, the discussion in this episode is intended to be informational and not for diagnosis. If you have any healthcare concerns, please consult with your physician. All right, Dr. Cohen, welcome to Sober Dad Crew.
Thank you.
You know, we're going to mix it up a little bit from our normal fare and talk about some men's health stuff. So, you know, first off, and what I invited you to talk about was vasectomies. And I kind of put out there on my social networks asking for questions. And you're probably not surprised by the largest question from the dudes is about, you know, sexual activity after. Will it impact? Is there any risk to sexual activity? Probably, like, that's because that's what men think about like 90% of the time. So, you know, before you kind of go into the, you know, details of the process, do you want to just tackle that one?
Yeah, that sounds great. So for vasectomies, it does not impact sexual function. The only impact, and ever so slightly, might be the volume of ejaculate that comes out. But the majority of the ejaculate volume comes from the prostate and the seminal vesicles, which are after the testicles. So really, less than 10% of the volume should be affected. The procedure does not affect the ability to have an orgasm, have an erection, or a sensation. You know, in the short-term period, there might be some tenderness and pain that might limit sexual activity, but that should subside rather quickly.
Yeah. So those who listen to Sober Dad Crew know that I've had a vasectomy, and it's probably almost my 2-year vasectomy anniversary. Not done by Dr. Cohen, but done by another urologist in Ithaca. So, you know, as you talk about it, I might interject a little bit about my experience, but can you kind of go over the general process from, you know, how you discuss with people whether they should have one? So when I had mine, I was 52. I had, you know, 2 biological kids and 2 stepkids. It was like pretty clear cut. I was old. I didn't want more babies. But, you know, how do you sort of guide people through the process of the decision making if they're unsure, or maybe if they're young and don't want to have kids? And then kind of what is that process of, you know, the appointment before the surgery and all that?
Yes. So I see all my patients for a consultation before scheduling the vasectomy. And it's for a couple of reasons. One, to just make sure that we're all on the same page. They understand what a vasectomy is and that it's permanence. And also to do an exam just to make sure this is feasible to do in the office. And just to get kind of that assessment of them. Now, I start by just asking a few questions about if they have children, how many, and if they're certain they don't want to have any or any more. And then I just assess that they understand that it's permanent, they understand there are non-permanent forms of birth control, and even though there are reversals, I wouldn't go into this counting on a vasectomy reversal. One, it's a lengthy and possibly expensive procedure, and it has varying success rates, the reversal, that is. So I do not discriminate in, you know, people by age or the size of their family in who is able to get a vasectomy. Now, if they are able to understand the risks and that it is permanent, I feel they are able to make their own decisions about family planning. So I am willing to proceed. The rest of the appointment is in that first visit is usually going over all the risks and the postoperative care and what to do beforehand. Would you like me to kind of jump into that now?
Yeah, I think that's a good place to start. And, I will verify I did have sort of a similar appointment, and there was sort of paperwork, where I attested my understanding of all that and am I sure I want to proceed, which did, not to jump too far ahead, happened also before the surgery.
Yes. And one of the reasons I do it before the procedure is I prescribe Valium for patients to take beforehand. Now, I would still do it even if someone did not take it, particularly someone who's sober and does not feel comfortable taking Valium. I think that would be something I'd be totally comfortable with. But I like to have that visit, before they take that medication.
Yeah, and
So,
I didn't do that. I don't remember if it was offered. I mean, I will say I was nervous, but not
mhm,
like, petrified kind of nervous, but that might be my own ability to sort of manage my nerves.
yeah. So the not every urologist does it. Two reasons I like to. I think it relaxes the patient. It also relaxes the muscles in the scrotum and makes the procedure a little easier. So when I jump into the risks of the procedure, I talk about fever, infection, very low risk, but it is possible. I also talk about postoperative bleeding, not really bleeding through the wound or anything, but there it is possible to have some. But the thing I get most concerned about is swelling in the scrotum, where it swells up like a big purple balloon, and someone needs to be taken back to the operating room to evacuate that out. Um, Very rare, but I talk about the precautions we take to prevent that, and I give people, a couple days taking it very easy, icing on and off, and then a week of no heavy lifting. And depending on some people's careers, they need a note for work for restrictions or just to be excused for that week.
Yeah, I had brilliantly planned for a Friday and then it got moved. So then it was a Monday and I had a busy work week. So I would recommend, because I was like walking across Cornell's campus at like zero point zero 0.01 miles per hour, trying
Yeah.
to get to a Chamber of Commerce event. It was dumb and I shouldn't have done that. Like, so that's my little PSA on that. I'll say I did have bruising. So what, can you sort of, and it was of no concern. So where's that line between sort of there's this bruising, which I think is common, and that sort of swelling you were talking about?
So, kind of the really active bleeding is where you have an expanding scrotum that's big and purple and getting bigger as you look at it. Now there's some in between that and just some minor bruising or nothing. Now I do say some minor bruising is normal, also a little bit of bleeding through the incision. Sometimes people have black and blue throughout the whole scrotum up to the penis. I don't see that too frequently, but I do hear about it. Uh, but I think even just a little swelling, either on one side or both, is normal. I wouldn't say normal, but nothing to really worry about. Maybe some people need to take an extra week, additional scrotal support, and go from there. Um, the other risks that I talk about that are definitely less common, chronic pain, that's pain that lasts months, even years. I do every once in a while see a patient who had a vasectomy like 15 years prior and they are still uncomfortable, but that's pretty rare. Also, about a 1 in 1,000 chance it does not work, but also pretty rare. And I'll touch on the next thing, which is that although the vasectomy is permanent, it doesn't work immediately. About 2.5 months later, I have people drop off a semen sample and we tell them if there's any sperm left in it or not. The recommendations were previously to do that twice, but that's no longer recommended. I think one is good enough. If it is still positive, I just have people check again in 6 to 8 weeks. If it's persistently positive, you may be that 1 in 1,000 where it doesn't work, and we go in and repeat the vasectomy. I've only seen that once, though.
I will say, having had one and knowing, there's cutting and cauterizing and clamping, it is why 1 in 1,000 seems unlikely when you've had the procedure and you're there. Like, this doesn't seem like it would fail, but
Yeah. But, those tubes are meant to go together, and sometimes they find their way back together. And then the other thing that I do touch on is there was data a while ago about vasectomies having an increased risk of prostate cancer. Um, this hasn't been repeated or shown in a way to really be repeated, and it might be more of a correlation instead of a causation. And the increased risk was really low. So, what I tell people is I think that getting involved with a urologist, whether it's time of your vasectomy or years later, kind of puts you at more of a chance of screening for prostate cancer and then finding it. So, I tell everyone that, most men I recommend to start screening between the ages of 45 and 50. And if there's a higher risk, such as a family history, maybe earlier than that. So the next thing I talk about is actually doing the semen sample about 2.5 months later. So we touched on that, and then I go into what to do beforehand and after. I tell people to bring loose fitting sweatpants and tight fitting underwear, such as compression shorts or jockstrap, to the day of the procedure. I tell them to avoid aspirin and ibuprofen or similar products 1 week prior to the procedure, but Tylenol is okay. Also, the Valium to take about an hour beforehand. I offer that to them. And if they're taking the Valium, they definitely need a driver. I do recommend everyone has a driver, even if you're
I
not.
wouldn't have wanted to drive afterwards.
Yes. And then I go over the precautions for, the heavy lifting and taking it easy the first 2 days. And then, I make sure they still want to go ahead with their decision. I have them sign the consent form like you described, going off all those things, and get everything scheduled. Anything on like that process that you have questions about?
No, I think that's pretty clear. And so then you schedule the appointment for the procedure, assuming it's a go. So what sort of day, what should somebody do sort of day of? There's the Valium if their doctor does that, but what other things, logically, good night's sleep the night before, that kind of
Yeah.
stuff. But are there other
Um,
things that are kind of good to do before the procedure?
so I do have people shave their scrotum beforehand. That's also in the instructions. I know some offices will shave it for you. We prefer they shave beforehand, but we do have stuff here in case that's needed. I always recommend people eat beforehand. Other surgeries where you're getting put to sleep, they tell you not to eat, but this, you don't want to be lightheaded and at risk of passing out. So eating and drinking is important. Other than that, getting a ride to the office, and then making sure you have it easy the rest of the day. And then for the actual procedure, we come in, my nurses just review the consent form. They get the patient prepped on the table with a sterile prep around the penis and scrotum and groin, and lay out some sterile drape on the patient with their head exposed. And then I usually come in and just confirm with the patient that they want to go ahead with it. And I usually review that they need to do the semen sample 2.5 months later and just the precautions for afterwards. And then just briefly go over the risks. And then I do talk the patients through it. Some people, you can really tell they just don't want to talk during it. They're very nervous. And I just talk less. Now, I describe the big thing I'm talking about during it is the local anesthetic or lidocaine we use. So the local anesthetic helps mostly with sharp pain. So I tell them if they're feeling anything sharp, they should let me know. And then, and usually they don't. But what is normal during the procedure is to have some, is to feel some pressure and maybe even some pain up in your stomach, like you've been kicked in the scrotum. The procedure itself takes about 15 minutes. And then my nurse goes over all the instructions again. We get you set up with an ice pack and all set to go home. I typically don't require people see me afterwards, but I always tell everyone they can if they want to come back in, and we're happy to see them.
I'll say the needle, in my experience, is very small.
Mm-hmm.
You didn't really notice that. And I think maybe once on each side, I sort of said, oop, it's a little more painful than it was. And I got a little more. So it was very like interactive in my experience, and like not really painful. The tugging for sure, the pressure kind of thing. I
Yeah.
mean, I think sort of the funniest moment in a way is when it's being cauterized. You're like, that's smoke,
Yeah.
like smoke where there's not normally smoke.
So we want to do multiple things to make sure the tubes of the vas deferens are not getting back together. So we cauterize them, we cut them, we clamp or tie them, and then we make sure they're in different planes within the scrotum, so they're not, basically make sure they're not near each other.
Right. And they don't kind of move around after you do that, or over time they might.
They may, but we can put in a stitch to kind of sew it into that place.
Yeah. So, a little more sort of detail in the surgery. So you make an incision on each side, and then is
Yes.
it internal? Are you pulling out the vas deferens like?
Great question. So, there's a few different methods. Some people do one incision. Some people do two. Some people do something called scalpel-less, where you still have to go through the skin. You're just kind of almost tearing it instead of cutting it. What I do is I use a scalpel and I just go through one incision through the middle, about a centimeter long. And what I do is just pull the vas deferens up to the skin on the scrotum, numb that area, and cut through it and grab it through there. And then I continue to use some numbing medication as I expose more and more. So I'm bringing kind of a loop of it outside the body, and then we cut it, clamp it, cauterize it, and put it back in the scrotum. And before we put it back, check for any bleeding.
Yeah, I'll
And
say I couldn't see any of it other than the smoke, and a little bit of like when they were clamping it. It was like you're working to get that clamp on there. But I I think it was so really easy that in my experience, I probably waited way longer than I should have out of my own sort of nerves and maybe place in life. But, um, right. I'll touch on the politics as people who listen a little bit know. I think it's a good choice, in a climate where women's right to choose is at risk, but it's also allows your partner to not be on hormonal birth control. And
yeah.
is probably a much less invasive surgery than a woman getting a tubal, I think.
Yes, it's definitely less invasive than a tubal ligation, which would require a full anesthetic in an operating room for women. And most people have been with their partners for many years before they're considering this. And you think of all the time they have been kind of managing the birth control, and this is a one-time thing for you to do. So it's really um, a nice thing to do in your relationship, assuming you're certain that you don't want any children or any more children.
Yeah, and in my scenario is second marriage. We both brought kids in the game, and mine are now 17 and 21, and my stepkids are 8 and 13. So I was like pretty darn sure.
Mm-hmm.
I love babies, but I'll hold out someday for the grandkids. So it was for me, it was really was felt like a no brainer and the right thing to do. But I was nervous. I mean, I haven't that was really the only surgery I've ever had, I guess, other than tubes in my ears when I was a kid. But I felt, the doctor was great. I was really relaxed. I think I was a talker, in part because I work at an architecture firm that does a lot of healthcare architecture. So we kind of had, stuff to talk about. Like, what do you sort of, when you're chatting, talk people through it, or do you just sort of go with the flow with what they want to talk about? Or
Yeah, some people, want to know the steps and what you're doing. Some people, they're just giving one word answers and you kind of tell they do not want to talk. So I just kind of leave them alone. But oftentimes, like my nurse who's assisting me will ask a question like about their kids, and then we usually start a conversation that way. And, we're in kind of this uh, rural community here where people usually have some connection to something you do around the area, and there's usually like common ground to
yeah,
talk.
we are in a pretty small kind of area. I mean, Ithaca's a city, but it's, for those who don't know, it's a pretty small city. How long have you been in the area?
I've been here a year and a half.
Okay,
Um,
well, welcome. I moved to the area in 1998, so I'm an old timer here, but um, you guys are settling in. You did tell me you had kids.
yes, I have two kids, 3 and 6.
Yeah. And this is the question I ask a lot of my guests, and this is a little pivot, and then we'll talk about some other things. But did you always know you wanted kids?
Um, I always kind of envisioned it. Um, I don't know if I had the really strong desire, but as my wife and I moved along with our relationship, it seemed like something we both saw as part of building our family.
Yeah. So we're going to pivot to a couple other sort of men's health things. So I've been really good about getting prostate exams along the way. But when I went in for the pre-screening, it had been, I guess, a year since my last, general appointment. And so the doctor was like, oh, well, let's just do this while you're here. And he did the exam, and I got a kind of a humph kind of look from him. And he said, oh, that something feels a little off there.
Mm.
And that particular exam was on a Friday. So he like scurried me right off to go get a PSA blood test. So it was like a long weekend,
Yeah,
waiting for those results to come in. And then, they were fine, which was good.
good.
But, like kind of talk through, like, I'm old, like, because my new doctor said, well, your prostate's fine. It's not the prostate of a teenager, but, you're like all good. So, like, when you're doing that exam, kind of what are you looking for?
So that's a great question. I'd like to just back up and kind of start with prostate cancer
Yeah,
screening.
yeah.
So, prostate cancer, most common non-skin cancer in men. Um, we talk about it, maybe 1 in 8 men will have prostate cancer in their lifetime. So there's a lot known about it. New treatments are coming out all the time. Um, the way and you say you're old, but I would consider you young in terms of prostate health. But the way we screen for prostate cancer, been around since the 80s, is a blood test called a PSA, prostate specific antigen. And by the name of it, it's specific to the prostate. It's not specific to cancer. So I recommend starting screening for most men between the age of 45 and 50. Sometimes men with high risk, like a brother or a dad who has prostate cancer, specifically aggressive prostate cancer, maybe starting that between the ages of 40 and 45. And a lot of people will say in those age ranges, like in the before you're 50, maybe just get one to get a baseline, and then start the annual or every other year screening at the age of 50. And I think that's fine. And there's things we look for, such as the absolute level. 4 is kind of used as a cutoff. But for guys under the age of 60, I maybe have a lower cutoff between 2 and 3, and then use that 4 for people above 60, because it does naturally go up over time. And then that can sometimes trigger a referral to a urologist. The other thing we can look at is kind of the rate at which it's changing. But you also have to keep in mind that a low value is still a low value. I'll sometimes get referrals. Someone said their PSA doubled in 6 months or something, and it went from 0.5 to 1. I still consider that very low.
Mm-hmm.
But I'm always happy to see people about questions about their PSA, even if it is low. And then the question is, where does, the rectal exam that you're describing, where does that come into play? So I think it's become less common, and there's mixed opinions and mixed data on how useful it is. So the way I use it is I typically do a rectal exam on men who are coming in for an elevated PSA or otherwise have some concerning risk for prostate cancer. So what we're looking for in terms of looking for cancer is really like a nodule or something popping out of the prostate. Now, the prostate's a 3-dimensional organ, and you're just feeling one side of it. And in some men, you can't even feel the whole side of it. In advanced disease, it could also be like really extending out of the prostate, or like invading into the rectum or fixed to other organs. But we rarely encounter that on an initial exam. The other thing, the other information we get about the prostate is a general idea of the size of it. Again, you're just feeling one side of a 3-dimensional organ. It's not a super great study to do that. So it's unclear the value, whether you should get one every year no matter what, especially if you're getting PSAs and they're low. I don't know how valuable that is. And the reason getting the size is a good measure is because if you have a larger prostate, you're kind of allowed to have a higher PSA. We use something called PSA density, just how much PSA per prostate volume you can have. And if that's lower, that's kind of seen as kind of protective in terms of your risk of having prostate cancer at that moment, not of forming prostate cancer in general. And then, so I know that wasn't a clear answer on, should you be getting rectal exams every year, but I kind of say I only do it if I think there's if there's a risk of finding prostate cancer, and rarely do I find it on someone who has an elevated PSA do I often find a nodule. So to say that, it's not like a negative rectal exam really precludes any findings of cancer.
Gotcha. So, what we should have probably started with too is, what does the prostate do?
So, great question. The prostate is part of your urethra, the part closest to the bladder, and its primary function is to make the seminal fluid, make the ejaculate, the fluid that's responsible for keeping the sperm healthy and alive until it reaches the egg that it's fertilizing. So, once you're past the point in your life where you're having children, that is the function of that is not crucial. Now, having said that, the ejaculate volume, the experience of ejaculating, is important to a lot of men in terms of their sexual function. So we have some medications, some surgeries that can eliminate that process, still able to have an orgasm, but nothing comes out. And to some men, that's a big deal. And we take that seriously, and we try to treat people based on their needs and their expectations.
So say, you do have an elevated concerning level, then, what are kind of the next steps that come after that?
So I kind of briefly go over everything I told you. I always caveat everything that PSA can go up over time. It can go up also transiently in times of stress or infection. But the only way to diagnose prostate cancer is with a biopsy. But the biopsies are invasive. We do them through approaches now that have pretty low infection risk, probably almost zero. But it's still a procedure and invasive, and a lot of people don't like going through it. So I try and do as much as possible, and this is pretty widely accepted as a process of doing some other testing to, one, have a targeted approach in your biopsy and possibly delay or eliminate the need for a biopsy. So one of those is an MRI, where we look for spots on the prostate that should be biopsied. I will say the MRIs are known to miss about 20 to 30% of cancers, so it's not everything. I also do some other lab tests, such as repeating the PSA with some other markers. Various ones people use. Some people just do a free and total PSA, which is basically just a fraction. The higher the fraction, the lower risk it is that it is thought that you would have prostate cancer. Another one people use is something called the prostate health index that uses the free PSA as well as some other markers. And then it gives you a score that can then be translated into a risk categorization for the risk of finding higher risk prostate cancer. There's also something called the 4K score, which is very similar to the prostate health index. And there is also a urine test that I don't use frequently, but I know some people that use it more. And this is used in a similar manner, where it's guys who have a PSA or borderline PSA, and you're trying to make the decision between a biopsy or not, and it kind of can help the decision one way or the other. So after getting that information, if I think a biopsy is necessary, we schedule it. If there's a lesion on the MRI that's concerning, we do what's called the fusion biopsy, where we use the real-time ultrasound images and the MRI images that were gathered to focus our needle on that lesion. We also biopsy the rest of the prostate. If there is no lesion, but still enough of a concern to do a biopsy, we use a template to make sure we're hitting all the parts of the prostate we need to. I do it through the transperineal approach, meaning the needles go through the skin behind the scrotum. This is a lower infection risk than through the rectum, which is how it was traditionally done.
And then is that a local anesthetic for that, or is it a general?
I'd say the majority of places do it with a local anesthetic in the office. But there are people that do it with, I wouldn't say a general anesthetic, more of a sedation like you would for a colonoscopy.
Gotcha. And so we're just like going from things getting worse. So then, say, it is cancer. My understanding is there's a pretty wide range of treatment options, and maybe this is my ignorance. It's a slow moving cancer.
Mm-hmm.
So where do you go?
So what I say prostate cancer is slow moving, but it can be aggressive, meaning that once it gets outside of the prostate, there's treatments for it, but you're never really going to get cured once it's outside of the prostate. So the first thing we do is put you into a risk category: low, intermediate, or high risk. Intermediate is subdivided into favorable, intermediate, and unfavorable. High is subdivided into high and very high. There used to be a very low risk. I'm pretty sure they got rid of that on the guidelines. If I'm wrong, sorry. And that helps us decide what steps we need to do next in terms of imaging to determine if the prostate cancer is localized or not, or and treatment options or management options. So for low risk and favorable intermediate risk, we usually don't require any further testing at that time, and just talk about treatment or management options. For ones above that, I usually recommend what's called a PSMA PET scan. If people are familiar, a PET scan is something done by our nuclear medicine radiologists, where they inject a radioactive tracer that can bind to cancer and then light up on a special type of CT scan. PSMA is a special marker that specifically binds to prostate cancer in the lymph nodes or the bones or wherever else it might be. And then once we determine if it's localized or not, we talk about your treatment options. And the three big buckets for that are active surveillance, surgery, and radiation. Now, active surveillance is probably a couple decades old now. The thought is that the risks and the side effects from the treatments are not insignificant. And maybe with some of these men, we can just watch their cancer and them and only treat them if it becomes more aggressive or possibly, delay treatment indefinitely. Now that involves usually repeated MRIs, biopsies, and PSAs. Usually I recommend repeating all of that within the first 6 to 12 months. And then depending on what we see, coming up with a schedule of every 12 to 36 months for depending on what we see. Now, this used to just be for low-risk cancer. Lately, in the past 5 to 10 years, we have started doing it for some patients with intermediate risk cancer. Now, I always tell people that's a little less tried and true. I find with those patients, I more frequently need to transition to treatment in a shorter time period. And for those, I do use some additional testing we call genomic testing, which looks at the gene expression in the actual cancer cells to look for features that might make it look more high or low risk as compared to other ones. I usually only order that testing for people who are on the borderline cases who may be candidates for active surveillance or not. Then, assuming the prostate cancer is localized, but they still recommend treatment or they want to go ahead with treatment, we talk about radiation and surgery. Surgery, the vast majority of them are now done through the robotic minimally invasive approach, where we remove the prostate, seminal vesicles, and the lymph nodes, and then have to sew the bladder back to the urethra because the prostate kind of sits in between those two. It's got those words like robotic minimally invasive, but it's still a big surgery. It can take 3 to 5 hours. So there's significant risk to it. We're going through the abdomen. There's other large organs nearby. There's risks of anesthesia to your heart and lungs. But, it is a fairly well-tolerated surgery, despite all that. The biggest effects that most people worry about, and that I worry about the most, are urinary function and sexual function. The prostate sits right in between the bladder and the sphincter for urinary control. So it's often damaged temporarily, sometimes permanently during the surgery. And for that recovery, we give people exercises known as Kegels. And, I would say most people within a couple months get to a place where they're pretty happy. But there is still a significant portion of people that are unhappy at a year and need to seek out other treatments, such as what we call slings or artificial sphincters. And it's a big deal. We're talking about, being dry, and that can really affect your life in significant ways. The other thing is the sexual function. The nerves that control erections run right by the prostate, and they need to be peeled off the prostate during the surgery. So these are damaged often temporarily, sometimes permanently during the surgery. And this recovery is a little less certain. I like to have an aggressive approach, starting people on daily Cialis before surgery. And then within a few months afterwards, if they're not having much activity, to start them on what we call intracavernosal injections, where you inject medication directly into the penis before sexual activity. And this gives you an erection almost right away. And this is something they may use for the rest of their life, or they may be able to wean off it as they recover.
Is that like
Now,
an EpiPen kind of
it's
situation?
not.
Is that a home thing, or you got Doc, the missus and I want to have a fun evening, and
So
how does that work?
it is something you learn to do on your own, and you learn to draw it up from the vial using a very small needle. It's a really small amount of fluid that ends up being injected. So it is something that you may recover from on your own. You may require that the rest of your life. But there is kind of a phenomenon of if you don't use it, you lose it, both in terms of sexual function and size. So I do recommend people consider that strongly. Now with radiation, you don't have that upfront hit of surgery, and but it does come with its own risks. It's maybe a little less certain of a treatment of the cancer, has a slightly higher risk of coming back 8 to 10 years down the road. But, even at those times, it's still treatable. And then it does have its own potential risks, such as bothersome urinary symptoms, burns to your bladder, burns to your rectum. But they're getting better and better at it, every day. A big thing is some of the higher risk prostate cancers also need hormonal therapy, basically a medication that blocks your testosterone, usually ranging from 6 months to 2 years. And that's a big deal, and that might make the decision for you between surgery and radiation. Now, all these are to treat cancer, and there's a chance that cancer comes back after one of these, and then you need further treatment, whether it's radiation after surgery or treatment for distant disease after either of them. And then within the radiation bucket, I'm not going to go into too much detail, but there are different types of radiation. There's the traditional external beam. There's something called CyberKnife. And then there's some other therapies known as focal therapies, which are getting a little more popular, but I think they need to be really selected for the right people, and they're not super widely used yet.
All right, there's
a lot of information.
It's
and
a
there's
lot,
more.
but it's good. And while we're on the cancer topic, let's hit one more.
Yes.
And this one, at least you have a little bit of, self-screening ability, and that's testicular cancer. So, commonality, and maybe, talk people through the self-screening, because that is one that you actually have the ability to, have some impact on.
Yeah. So testicular cancer is way less common than prostate cancer. But it is the most common cancer in younger men. So it is most commonly found in ages from 20 to 45, but it is often found by feeling a lump on your testicle, whether it's by you or your primary care doctor. Now, I would say the big thing I said at the beginning of prostate cancer is how aggressive, how slow moving it is, and then aggressive it can be. Testicular cancer is fast moving, but very treatable. Even at distant sites, the example I always use is when Lance Armstrong was diagnosed, he had disease in his brain, and he was cured ultimately. And that's an advanced stage, and he's lucky he did very well, but that's all in the realm of possibility for testicular cancer. And the first step in, after it's diagnosed, usually confirmed with an ultrasound, is to get some labs, do a CT scan to look for any disease inside the belly. That's the most common place it spreads is the lymph nodes inside your abdomen. And then to remove that testicle, and then we send it off to the pathologist. There's many different variants of testicular cancer, and that can help us determine what treatment is necessary for those men afterwards. Most of them are very responsive to chemotherapy. Some people require removal of all the lymph nodes in their belly. Some people are okay just being observed with serial CT scans, which is how we watch for testicular cancer recurrence.
So walk through, the self-exam, which I think is very much like the exam your doctor gives you, but obviously they're doing it. They know what to feel like. If I'm doing it for myself, like what kind, like, is it hard? Is it, what am I looking for?
So the typical, I'm actually not, I'm not certain what the current recommendations are for self-screening. But, most people will feel their testicles while they're showering and stuff. So it's not like it's a huge burden to do it to yourself. And maybe it'd be good to once a month just have a more thorough feel than usual. The typical testicular cancer is hard lump or abnormality on your testicle. Now, if you feel anything that's abnormal and out of place, it's perfectly reasonable to tell your doctor. An ultrasound is a quick, inexpensive, harmless procedure to really get a good answer. And it really, like, having a false negative on a ultrasound for like a testicular tumor is probably unheard of. But so it's really something, if you feel something abnormal, always okay to check it out.
Yeah, better to be wrong.
Yes. And it's really not an invasive way to check.
Well, this was great. A ton of good information. I really appreciate you taking the time.
Thank you.
And I think part of the mission of my podcast is to make sure people, try and have healthy lives, and this really helps with that. And I think answers a lot of questions that people aren't always wanting to ask, or even, think they're going to ask their doctor, or think something's not a big deal. So this is really valuable, and I really appreciate you taking the time out of your day.
Thank you. It was a good experience.
Thanks for listening. Sober Dad Crew is a DIY project by Stephen Kimball, who writes, edits, and produces the show. To support the show, please review it where you listen to podcasts, or visit soberdadcrew.com to buy some merchandise or make a donation.